like you at home, like us clinicians, we like to keep it up to date with what's going on. And we read the literature, the published material on our subjects, and look at the media for developments. It's always useful. Ken was just talking about retinoscopy, which is a very tried and tested method of detecting keratoconus, to put all the modern developments in historical perspective. I've always felt that very important. So my main clinical areas of interest, I work in the keratoconus clinic, I also do a big contact lens clinic, but I'm not going to talk about those today. I've just picked several topics that I've just spotted over the last couple of years or so, just to share with you really, just all relating to keratoconus. Some of them are things that are changing, and Steve has already mentioned some of those already. And there are other ones that are sort of in the pipeline, but not really available, being used yet. So we've already heard about corneal topography, also known as corneal tomography. They're different things, but for the sake of argument, the same. This is the basis of reflecting something from your cornea, regarding your cornea as a mirror. And centuries ago, it was known that what you saw on the person's cornea may be distorted. And in the first, if you like, instrument that was available was this thing called a Placido disc, which is shown in the upper left side. And this was designed in 1880 by this ophthalmologist called Placido. And you can see on the other side, there are images of a normal cornea where the rings are nice and regular. And then below that, drawings from about the turn of 19th century, 20th century of images of rings on patients with keratoconus. So, of course, we move forward with technology, as we've been hearing, and we now use, there are various systems, Pentacam is just one of them, using the principle of looking at reflections from the cornea to look at its shape. We also carry out a procedure called pachymetry, which is measuring corneal thickness, because we know that keratoconus is a thinning disorder of the cornea. And we also assess refraction as well. And these are our three methods, really, apart from taking a good history and so on, of trying to detect keratoconus in a patient. And as Steve has already outlined the background to the images here, these are actually three normal patients. There's nothing wrong with these patients. But we get these contour maps, which are really defining shape and therefore power of the cornea. These are all abnormal. So we have, every patient with keratoconus has got a slightly different variation on their topography map, although there are classification systems for broadly putting the maps into categories. So we get all sorts of pictures here. Steve showed some other ones. There's some different ones here. And so, talking about advances in detection, we've moved from holding a table tennis bat with a lens looking at rings, and we still see these in some eye departments, not necessarily being used, but in the back of a cupboard, to very sophisticated methods of analysing the topography or tomography maps. It's extremely sensitive to looking at change. And in this era where we now have a treatment for patients with progressive keratoconus, we need to monitor change very carefully. So I'm of a generation where we say, well, you've got this condition, glasses will be okay, we'll try some contact lenses, you might need an operation, and that was it. And of course, we're now in a completely different era where, as we've just been hearing, we need to be looking at younger patients, children, screening, because we do have a treatment which is known to work. So the technology of tomography and assessing patients is highly advanced. It's a very interesting discussion just now about community optometrists. Just to add something to that, there are some community optometrists who do have corneal topography. Your average corporate company is unlikely to, although they now have retinal imaging, so it may come. But it is expensive, and I agree with Ken that some of the other old methods are useful, but of course you can't integrate it with any other measurements really, but there we are. So developments in tomography, very significant. The other question that patients often ask us, so I work in a hospital clinic, some keratoconus patients attend private practice for optometry, is patients saying, well, what's going to happen to me? Are things going to change? You know, am I going to get blind? Am I going to get worse? How much? And so on. We get these questions quite a lot. So there's lots of work. There are 2 papers here from Moorfields from the early 1990s. Friends in college, Steve's on one of them here, looking at prognostic factors. In other words, what's the chance of me getting worse? Or what are the risks for me? So we've always been interested in that. And there's lots of literature on this. These are just two papers from Moorfields. And the consensus from these papers essentially was the younger you are at diagnosis, the more likely the risk, the higher the risk. The steeper your cornea at diagnosis, the greater the risk. And therefore, the curvature of the initial contact lens is fitted on that steeper cornea, you're more at risk. And we've known for a long time that ethnicity, racial group, has a significant effect on risks of progression. So this is older work now, and most clinicians sitting in their practice keep these criteria in mind, of course, and these are our standard answers to patients' questions. However, there's a lot going on, and Steve has nicely introduced this for me, so I don't have to cover it now in too much detail, but there's a lot of work going on now using artificial intelligence, essentially, and I'm not an expert in this, to number crunch the data to make it much more precise in terms of looking at change and progression. Because essentially, when we're talking about change, we're saying, has the cornea got thinner? Has it got steeper? And those are our two, and has the refraction changed? The astigmatism, has that changed? And this is the essential criteria that we're looking at. But artificial intelligence allows us now to look at that in great detail in terms of being able to inform a patient, really. Now, I know that Howard Mail, I don't know him, but I know he's one of the PhD students that Steve referred to. He's done a lot of work on this number crunching exercise using artificial intelligence, and I'll talk a little bit more about it in a couple of slides' time. The scientific reports paper here, everything on these modern screens is very small, which is a shame, but they were looking at another way of trying to improve detecting change, really, in corneas, in keratoconus. And the last one I'll come on to in a moment, the third paper on the other side. Apart from tomography, refraction, corneal thickness, we're also quite interested, and there is equipment now for measuring corneal stiffness. Because you'd think intuitively a thicker cornea would be a bit less flexible than a thinner cornea. It kind of sounds logical. So this has been now put into a piece of equipment, and there may be others. The one I'm aware of is a thing called the Corvis analyzer. And we can now derive for an individual patient or an individual a client who may just be coming for screening, a thing called the biomechanical index. So we can now give a number to how stiff or how flexible an individual cornea is, but also is it changing? So there is another element that could be looked at as well. But going back to that question about equipment in practices, of course, this all costs money. So I'm not aware of hospitals yet using this as a routine. So the principle here is that if you, and it's a little bit like when you go and have that air puff test to measure the pressure in your eyes for glaucoma screening, what's happening here is that we put an air puff onto the cornea and it flattens or applanates the cornea. And the system here essentially measures how quickly that happens. And obviously, if it's a stiffer cornea, it bounces quicker. If it's a softer cornea, it's slower, and so on. And this equipment is marketed partly for keratoconus diagnosis, also monitoring change before and after cross-linking treatment, but also in terms of glaucoma management as well. I'm not going to go down that avenue, but glaucoma management relies very much on corneal shape and thickness and so on. So another bit of kit that you may hear about, I'm not quite sure how widely that is being used by clinicians at the coalface with keratoconus patient, but there's been articles written about this. And of course, actually the Corvis is made by the same people that make the Pentacam, which is probably at the moment the most widely used equipment, certainly in the NHS, not exclusively, and there are other bits of equipment. But you can now pair these two bits of equipment together to give yet another index of corneal mechanics and measuring change, really. So it's just a useful development. It's not brand new, it's been around a few years, but you can see the logic of measuring corneal elasticity. Just returning to the work that Howard Mail has been doing, now the language in artificial intelligence is beyond me, so I'm not going to talk in technical language. It's something that he will be able to talk, and he has spoken to this group, I think, within the last year. There's a massive database of patients at Moorfields, I mean, the biggest in the country by far. And so you've got a large supply of people who can volunteer their time to help with the research. So in this article here, he looked at more than 8,500 patients and used a modelling technique to basically work out what the risk of progression is. Now, Steve will know more detail about this project because he's involved with it. And I understand that more recently they're now developing a risk calculator. Now, I haven't seen this in action, I've not seen the detail of it, whereby presumably data can be input, looking at things like corneal shape, thickness, elasticity, and so on, and trying to work out the risk of the patient getting worse. Now, you may well have heard a colleague of ours, Marcello Leucci, speak here back in the spring, reporting the pathways at Moorfields for the cross-linking service. And I think the plan certainly here is that you'll be able to use this risk calculator when dealing with patients to plan their appointments, because it's such a busy place. Other departments are busy, but not as busy as here. And to be able to triage patients and give some empowerment to patients as to how they're being treated and how quickly and so on, but particularly for planning cross-linking appointments. Essentially, at the bottom line of this actually is more or less the same as those early papers, say from the 1990s, showing that the age at first presentation is one of the key risk factors, and corneal steepness and thickness. So that part of it hasn't really changed, and why should it? But the modern method of number crunching artificial intelligence to analyse this is a big step forward and producing a lot of very useful information. So that's a development in assessing, diagnosing and progression, really. Another question that we get asked in the clinic quite regularly is, am I going to get worse? How long is this going to go on for? Will I need my contact lenses forever, etc., etc.? So what about age and progression? And the standard thing that simple clinicians like me come out with in the clinic, and you've all heard this, is, well, your cornea, it'll get better when you get into the mid-30s to late, or it won't get better, but it will stabilise when you get into your mid to late 30s. And there's a natural stiffening of the cornea with age. So that's what we would normally say to a patient. But then we've all had surprises in clinic. And there's quite a body now of literature. There are just some articles on here, again, rather small on the screen, of what we would call late presenters. So those clinical people here will have seen patients coming to their practice or their clinic in their 40s, even in their 50s sometimes, and saying, well, I've never had this problem before, or it suddenly got worse. So it is known that progression can happen. I can't give you a figure as to the likelihood of it happening in someone over 40, but there's quite a lot of interest in this. And there's also publications recently on how effective is cross-linking treatment in older patients. And it has been shown that it is as effective. So it's just worth bearing that in mind. But the majority of people will stabilise. And so I'm not trying to worry people, but there are some. There's no clear explanation, as far as I'm aware, of why certain patients will get worse when they're older. Higher authorities might know more. A little bit on cross-linking. We're going to hear more about this shortly. So I work in a department where we provide this service, just like they do over the road here. Cross-linking is not particularly new, of course. I don't know if anyone here has had this procedure carried out. Sort of first developed in the early 2000s and got government approval through NICE in the UK in 2013. the procedure, if you've had it done, is probably this one called the Dresden procedure, where the surface of the cornea, the epithelial layer, is removed. The active ingredient, the riboflavin, is applied to the cornea, and the eye is, if you like, irradiated with the UV light. And this is, as far as I'm aware, and certainly in the hospitals that I've been connected with, is the standard way of doing it still. The thing is, the epithelium is a really key part of the cornea. The epithelium isn't affected particularly in keratoconus, but it's a very important barrier to protect infection and to protect the eye. So if you start taking the epithelium off, it will recover in about 24 hours or so, but there is a risk of infection. So it's not without risk cross-linking treatment. And some patients' epithelium doesn't grow back quite so quickly and can be quite slow to recover. So there are risks from this procedure of taking the epithelium off. So just a few little, just for information really, I'm not a surgeon, but I've read the literature on this. What about leaving the epithelium on and trying to get the chemical through it? So I think it's quite a tight thing, the epithelium, to get anything through it. And there's lots of discussions about can you do it, and there's lots of attempts have been made over the last 5 to 10 years to get the chemical into the cornea without taking the surface off. I think the jury probably, as I'm not a surgeon, but I think the jury is still out on this in terms of how effective the treatment would be if you didn't take the epithelium off. The picture here just shows a cornea with some anterior stromal scarring, and that is another risk of tinkering with the epithelium if you go too deep. So these are the risks of this procedure. In a little bit more detail in the process of cross-linking treatment, oxygen is very important in the chemical being effective, the riboflavin being affected. So there have been trials using enhanced oxygen supply whilst carrying out the procedure. Again, with mixed results, I think, really. The way the epithelium is removed from the cornea, if you've had it done, well, you'll have been on your back and had it done, you won't have felt very much. But it's quite a basic procedure, really. We just sort of soften the epithelium and scrape it off, really. But one way or another, it's quite, you can imagine doing that on your skin. And that's the way it is done, really. So there have been approaches to remove the epithelium using laser. That will get a very smooth removal of the epithelium. But, you know, have you got a laser in the treatment room at the right time in your hospital? Probably not. So, again, lots of research goes on to try and improve the effectivity and the safety and the efficiency of cross-linking treatments. And there's been quite a lot published on, well, if we do cross-linking, it basically will freeze the shape of the cornea. That's the idea of it, to prevent progression. So if you can optimize the shape of the cornea and then fix it, that would be a bonus, wouldn't it? That would perhaps mean you might not need contact lenses, you might get better vision because the refraction was changed. So quite a lot of publications like one of the ones on here looking at what they call CXL plus, using other things as well as the chemical to fix the cornea. And finally, just this caught my eye. If you've had this procedure done or if you've heard people talking about it, typically you'd have one eye done at a time, or you may only need one eye doing at a time. But it's quite a peculiar thing for some patients to keep their eyes still. You've got to be pretty steady with it, not moving around. And so this is an American product, which is essentially a scleral contact lens that you can put the riboflavin in the middle one with the yellow, and then put the whole lot onto the cornea. So this is an epithelium-on approach. And then there are a couple of wires attached to the shell, to the lens, for delivering the UV. And there's a version to supply oxygen as well. So everything all in one. And in fact, they talk about being able to treat both eyes as well at the same time, if it's needed. The big benefit for the patient is that you can move your eyes with it. So I'm not aware of this being in any NHS facilities at the moment, but it just caught my eye as an interesting development. So the other thing we get asked is, if I have cross-linking treatment, will I need it again? How long will it last me? These sorts of questions crop up regularly in clinic. So there have been, again, quite a few publications since we started doing this procedure over the last 10. Prior to NHS, it was done privately, of course, as well. So for 10, 15 years. Most of the articles are over a period of about 5 to 7 years, showing safety and long-term effectiveness. But there is the occasional patient, which is why we monitor patients after the treatment for some time, that are going to need a redo. They're going to need it again. I can't give you a figure on what percentage of those patients there are. This is just an illustration from an American review, 2021, just looking at, so on the first picture on your left is after treatment, and then the middle one is 10 years later. And the green picture is a measurement of change, and there is no significant change here. So that's encouraging. In this, they pick their best picture, of course, as we do in these articles, but they're fairly confident that in their sample, they were happy with the effectiveness. So just a reminder, really, that cross-linking treatment is to stop progression. That's the essential aim of it. And so typically we would say 90 to 95% success rate. But actually quite a proportion of patients, the shape of the cornea changes, usually an improvement in terms of, say, being able to wear their contact lenses better. They may need refitting, but that's a sort of, in a way, an unanticipated effect of cross-linking, because the original idea was to stop it getting worse. And also, because if we can improve the shape of the cornea, the patient, in theory, you should see better. So sometimes we get this, sometimes we don't. But it's encouraging anyway. Now, I know that another member of staff at Moorfields, Frank Larkin, has presented his information on this, the Keralink study, which is fantastic, useful data, really, for us. Keratoconus is rare in children. Youngest patient I've seen was about 6 or 7, I think. There may be younger patients still. So it's pretty rare. But patients ask, should I go and get my kids checked at the optometrist? We get these questions in clinics. The NICE guidelines that I showed earlier on, at the moment, only actually apply to adults. But work, I believe, is going on to get this revised to also include children, paediatric work as well. And, in a young child, it's tricky to measure progression. We're talking about diagnosis earlier on, but also to get accurate measurements of progression. Again, you can imagine it's tricky. And in a younger child, under 10, with problems with fixation, looking into the machines and so on. And also, how reliable is the topography in a younger child? These are all the things we have to grapple with, of course. I have to say, going back to what Ken said, doing the retinoscopy procedure on a young child is probably much simpler, and you can chase the child with the retinoscope. But anyway. And also the risks of treatment and the risks of a young child, you've got to have a general anaesthetic. You've got to put the child to sleep to do this, and there are risks with that as well. So all these things have to be considered. So this fantastic paper really looked at 60 patients. Now, these are slightly older children, young patients, they were 10 to 16. And basically showed that after 18 months, Kmax is the steeper corneal meridian, was stable after 18 months. So the bottom line here was that corneal collagen cross-linking is safe in younger patients. And of course, now I understand that the project is now continuing to look at longer-term stability. And if you've got a young patient with keratoconus, is their rate of progression going to be faster than if it started later? Because intuitively, you think it probably would be. So the longer term review of these patients will be very important, really. Certainly in some of the units that I've dealt with, so away from the research sort of setting like here, is that if we get a younger patient and that we know they have keratoconus, actually, despite the nice guidelines, a lot of ophthalmologists will just treat, okay, even without signs of progression. Now, I know this goes on in hospitals, and it probably is the best thing for the patient, because if you can arrest the keratoconus early, they may never need contact lenses. They may never need all that hassle that I know a lot of you have to go through day by day. So it's a very interesting area, this, and lots of work still going on. Other surgical developments. Now, I'm not a surgeon. I know we have a surgeon sitting here. I saw on the group forum, probably back about May time, someone asked a question. They were trying to arrange some treatment or something for their son, I think, talking about an implant to be put into the cornea, and was asking for advice through the forum about this. And I'd come across it in the literature anyway. So there's a thing called the Xenia corneal implant, which is currently marketed. So this is and the idea of putting implants into corneas to change their shape is not new. There's been a lot of stuff over many years looking at it, not necessarily to do with keratoconus, but to do with changing refraction and refractive surgery. So lenticules being put into the cornea, it's not a new thing. But this is being marketed actually by one of the big optical companies who do perform various surgical procedures. So I think this is where this patient's mum had come across it. If you're here, I apologise for talking. So what this is, the Xenia is a lenticule, a small lens made from a porcine collagen, which has been cross-linked, so it's stiffened by cross-linking. And you're not going to be able to see this because we have this small screen, but the surgeon puts a pocket into the cornea and then inserts the lenticule into that. And the lenticule, because it's stiffened, it will stiffen the cornea. That's the essential principle of it. So having talked to some surgeons about the kind of concept of this, I think the reservations are the collagen may well change shape, even though it's been cross-linked, it could change shape inside the patient's cornea. And collagen actually can also dissolve. Many, many years ago, there was an idea of making a contact lens from collagen. And it was the perfect disposable lens because they dissolve. And we do still use them occasionally for certain applications, not in keratoconus. So there's some reservations about that in terms of long-term safety and stability of the lenticule, the Xenia. And also, why wouldn't the keratoconus necessarily progress anyway? How is the surgical decision made that the time is right to do it? So just so that you're aware of this is the thing that's going on. But interestingly, I was thinking back again to times in the past at Moorfields. A former colleague here, there's a procedure called epikeratofakia, used for various things, but he was looking, Brett Halliday, who was looking at the effectiveness of, it's slightly different, but it's still a lenticule being attached to the cornea. And he was claiming quite good results, but actually it kind of came and went. So all these things can come and go. So I would always urge caution in terms of these miracle cures for all sorts of things, really. A couple of other things that I came across which are interesting. These are much more in the pipeline. So the idea of using stem cells. So stem cells are, you hear lots about this in medicine generally. But stem cells to try and improve structure of the cornea. So this was an article I think came out at the end of last year looking at stem cells being implanted into the cornea with donor cornea tissue as well to essentially the cells replace, the stem cells generate new keratocytes, which in theory replace diseased keratocytes in the corneal cells. And these authors claim an increased corneal thickness as a result. So that's a good thing because you've got a thin cornea because you've got keratoconus, and also improved vision. So interesting thoughts. But I think this is very much in the pipeline in terms of longer-term stability and so on of the cornea. So that was an interesting thing I came across, just another surgical approach. And another one which is very much in the pipeline, but some people are quite positive about this, surgeons that I've spoken to about this, the use of eye drops to treat keratoconus. So what's this about? So there's an enzyme in the cornea called lysyl oxidase. And it has been shown that in keratoconus, this enzyme is deficient. And as a result, you can end up with a reduction in the number of corneal collagen crosslinks. And our expert on this may talk about this later, I don't know. So the enzyme itself is what they call a cuproenzyme. In other words, it requires copper ions in the system for it to work properly. So there must be, according to their results, certain patients where copper is deficient. Now, why might that be? And again, we talked about environmental and geographical influences on keratoconus earlier on. So there could be environmental, there could be dietary factors coming into this. Why would this, in some patients, result in a reduction in copper in the body? So this drop is being developed. They've had 2 phases of research. They're now into phase 3 of development of it. IVMed-80, the trade name for it will be, is a copper-based formulation. 1 drop twice a day for 16 weeks. This is what they're talking about at the moment for their trials. And they report corneal flattening, reduction in steepness, reduction in astigmatism, and improvement in vision. So there you have it. We wait and see. So on to environmental factors. Steve has mentioned this before, and there's been a lot written about this. This was a review article that came out a couple of years ago from a big New Zealand group. Charles McGee, an ophthalmologist trained in the UK, but he's been head of this department there for probably over 20 years in New Zealand. So the enigma of environmental factors in keratoconus. So it just gives a fantastic summary. It's very readable. And Steve, in fact, has more or less summarised this anyway, really. So environmental factors, it's not just the air and the wind and everything, but things like eye rubbing, atopy, floppy eyelid syndrome, and so on here, listed here, are all potentially connected with development of keratoconus. But in this article, they talk a lot also, and this is another article, about nutritional and metabolic effects or deficiencies in imbalance in keratoconus. So this is quite a tricky area. What they're talking about here is, what evidence is there that dietary and environmental and nutritional variation can have an effect on the cornea to produce keratoconus? So we know in ophthalmology that if you've ever come across a patient or a relative that's got, say, age-related macular degeneration, it's pretty well accepted now that certain dietary modifications would be recommended by scientists and ophthalmologists. I don't think we're anywhere near that stage with anything like corneal problems. But there's a couple of articles here just looking at certain vitamins, serum levels of minerals being abnormal in patients with keratoconus. So there must be something going on here. Whether the evidence is entirely conclusive, I'm not quite sure. You've probably heard this expression oxidative stress. It's widely used for all of us, for our health. So what's going on here is that we've got free radicals, which are molecules released when the body breaks down food and by environmental exposure to radiation, ozone pollution, tobacco, etc. And this can damage cells in the body in a large range of ways. And an antioxidant is a chemical which protects the cells from the harmful effects of free radicals. So oxidative stress is a sort of imbalance between these two. We've all got this, but we have different control over the balance of it. And we know that various parts of the eye are affected in different ways by oxidative stress. And interesting, in this American illustration here, keratoconus is mentioned. So it's worthy of thought, this. There are some quotes here from literature on dietary supplements. Quite a lot been published on this, reporting increased systemic oxidative stress in keratoconus. Oxidative stress may contribute to keratoconus. The beneficial effects of antioxidants, etc., etc. So this is coming from scientific literature, so there must be something in it, but we're just not entirely sure yet how to advise our patients. There is one product that I've come across, an American product here, which has these constituents in it and is marketed for helping and stabilizing keratoconus, or your cornea in keratoconus. So antioxidants in it, copper, and various other things to protect the cornea in fighting keratoconus, really. I've not managed to identify any product like this in the UK, but it's interesting that what's going on here, really. Please don't ask me if I should take anything, because I don't think any of us would absolutely commit to it yet. But there's certainly a lot of interest in this in terms of what's going on. So that's me done.